Hi, this is Dr. Stephen Allison. Welcome back to our series of videos on ophthalmology made easy. Uh, we're going to talk today about pupil abnormalities associated with ptosis, and abnormal movement of the eye. So for that, we need to just nail down three basic principles before we start. First of all, it's eye movements. We need to know how to test the eye movements properly, because if you cannot do that, we're at sea really, and the eye movements give us insight into three nerves, into the fourth nerve, the sixth nerve, and the third nerve: oculomotor nerve, trochlearis, and abducens. So if you can test the eye movements properly, you know whether those three nerves are working or not. Very important. So let's dive straight into the eye movements. Now, it's very important to remember that the only way that you can measure the muscles, there are 6 muscles that move the eye, the 4 rectus muscles, and then your superior oblique and your inferior oblique. Now, for you to test those muscles, they need to be in line with the organ that they're moving, the eye. So once they're in line, and then you can test them easily. But once they're not in line and oblique, you are getting a mixed picture. So how do you get them into line? First of all, your rectus muscles are in line anyway. Your medial and your lateral rectus muscles are in line anyway. So you can really just say to the patient, take off his glasses, have a look at his eye, and say to him, look to the right, look to the left. In the beginning, really, when you're starting out, look at one eye at a time. Just makes it easier. So look to the right, look to the left. When he looks to the right and this eye moves outwards, he's abducting the eye. It's abducens. It's number 6, the 6th nerve that you're testing, abducens. And when he looks medially, it's the 3rd nerve you're testing with the medial rectus, because they're in line anyway. So those are easy ones. You just wave your hand in front and you know exactly. If he cannot look laterally, if his abducens is not working, he's probably got a 6th nerve palsy, and he will have, if he turns his head in the direction of the palsy, then he gets a massive ptosis, a massive diplopia. If he moves away, then that abducens is working, this one is not working, it doesn't really matter, and his diplopia disappears. So don't worry too much about the diplopia, but it means that the lateral rectus is working or not working, the medial rectus working or not working. They're in line anyway. The problem comes in with the superior and inferior rectus and the superior and inferior oblique muscles, because in the primary position, the straightforward looking position, your superior and inferior rectus muscles are not really exactly in line, and neither are your superior and inferior oblique. So you're not really testing them by saying to him, look up, look down. You have to get them into line. Now, how does that work? Let's try this. Here is your left eye. There's your nose. Here's your left eye. Your muscles come from the common tendon at the back, at the apex of the orbit. So what happens is, the eye is looking slightly forward. This is primary position, so it's slightly at an angle to where the muscles are coming from. So they come from the back here and they sit on the eye. This is the superior rectus, the inferior rectus. Now, to get the superior and inferior rectus muscle into line, you need to abduct the eye slightly, 23 degrees to be exact. So you need to abduct the eye. That means the superior rectus muscle is in line, the inferior rectus muscle is in line, and if you ask him to look up, superior rectus, look down, inferior rectus. Both of those 3rd nerve. So it's easy. So you can only truly test the superior and inferior rectus muscles if the eye is in the abducted position at 23 degrees. Right. Now, superior and inferior oblique muscle, very important muscles because it's a different nerve that innervates it. Superior oblique muscle comes, there's a little trochlea above the nose, and then dives back again to past the equator of the eye, and at an angle of 50 degrees. The inferior oblique muscle comes and sits in a similar position from the bottom. So how do you test them? The only way to get them into line is in the adducted position. Adducted towards the nose, 50 degrees to be exact. So if you pull the eye inwards, you ask him to look inwards, then the superior oblique muscle will roll the eye down. The inferior oblique muscle will, in the adducted position, roll the eye upwards because it's sitting beyond the equator. So the inferior oblique muscle rolls the eye up, the superior oblique muscle rolls the eye down. So if he has, in the adducted position, an inability to look down, the fourth nerve's not working. The superior oblique muscle is not working. The inferior oblique comes into play more with strabism testing. So, but for your purposes, superior oblique muscle, very important. So let's go on to that. Let's have a look at our patient. We ask him to look straight ahead. We test his medial rectus, his lateral rectus. To test his superior and inferior rectus, we ask him to look 23 degrees outwards and say, okay, look in this position, look up, look down, right, the superior and inferior rectus muscle is working. To test his superior and inferior oblique muscle, we have to let him look inwards, look as far as possible towards his nose, adducted position. And if he can look up, the inferior oblique is working. If he can look down, the superior oblique muscle is working. Superior oblique is important for us here because it's a different nerve. It's the trochlearis, the fourth nerve. Right, you got that? So you can't just wave your finger in front of the patient and say, can you see my finger, and move it backwards and forth. You've got to have a muscle in mind. And to test the muscle, it has to be in line. Right, so we've got eye movements down. Actually very simple. So now, there's a second principle that we also need to just nail down right now before we can carry on. And that is that you have two systems, two basic systems in your body, parasympathetic and sympathetic. Parasympathetic is your relax, your regenerative, your gut movement, you're digesting your food, you're in a limbo mode. That's parasympathetic. Sympathetic is your fight or flight. In other words, you get an attack or you get an exciting thing happening, and your system kicks in where you've either got to run away from this thing, catch this thing, or work with this thing. So you have your sympathetic system kick in. Sympathetic system, what does the sympathetic system do in the eye? Obviously, you need more light when you need to fight or run away from the lion. You need more light. That's the sort of the general principle. So if you need more light, what must happen? The palpebral fissure must open slightly. Nobody has ever said, well, here's a lion, let me run away. You go, there's a lion, I need to run away. Or there's something I need to catch, let me go and get it. So your eyes need to be open slightly, more than normal. Okay, so you need a palpebral fissure that's slightly more open than normal. And what must happen to your pupil? Easy way to remember, you need more light in a stressed situation. So your pupil will dilate. So your sympathetic system will open your palpebral fissure slightly and will open your pupil. You'll get mydriasis. What also happens is you sweat more, a little bit more, because that is your air conditioning system, with the latent heat being taken up when the sweat evaporates and cools you down that way. Right, so you get a sweaty brow, you get a palpebral fissure slightly more open than normal, and your pupil slightly more open than normal. Right, so that's sympathetic, parasympathetic. The third thing we need to nail down just quickly is, remember we said that 6 of the cranial nerves have something to do with the eye. The first one is your optic nerve, is the vision nerve. The third nerve, your oculomotor nerve, is most of the movement of the eye, internal, external, and even your lid. Okay, that's the third nerve. Fourth nerve, superior oblique muscle. Fifth nerve, sensation to the eye, your trigeminal nerve. And then your seventh nerve is your most important one there for closing of the eye, or mimic muscles. Right, so with that in mind, let's think about the eye. Rather than muscles, let's think in terms of nerves. Is what nerve then opens the eye? The oculomotor nerve, because it's not only the eye that it moves, it also moves the lid. It opens the lid. which nerve closes the eye is the seventh nerve, the nerve to do with the mimic muscles in the face, your orbicularis muscle. All right. So if you've got a seventh nerve palsy, a Bell's palsy, or one of those, which are very common, what's going to happen? The eye is going to hang open. It's an inability to close his eye. What happens if he's got a problem with his third nerve? The eye is going to have an inability to open. Right. So we've got that as background. Let's do something clinical. We get called to casualty, and a patient has a recent onset ptosis, a mild ptosis, and they don't know what's going on, and they ask you to come and have a look. So you have a look. Now you've got fresh knowledge in your mind. You know that you've got to test the visual acuity. You test his visual acuity. That's normal. You go through all those tests. You test his pupil, and you go, ooh, he's got a smaller pupil than normal on the ptotic eye. Smaller pupil. Okay, so there's an abnormality. You do his eye movements. You know how to do them now, hey? Medial, lateral. Look in the abducted position, superior, inferior. Third nerve is working. And then you do the superior oblique muscle, which is inwards and downwards. Yeah, that's working. Okay, so his eye movements are normal, but he's got the small pupil and he's got a ptotic eye. Then you remember that sympathetic may be coming into play here. So you want to know whether he has sweat on his brow. The best way to do it is with a pen, just a plastic pen, and you rub it over the normal side, and there's a little bit of resistance because of the sweat. There's always a little bit of resistance, and you rub it, and there's a little bit of resistance. You go on this side, which respects the midline, and it just falls. And it just falls. That means there's no resistance, there's no sweat on that side. So the problem here is Horner syndrome. He's got a ptosis, a meiosis, and anhidrosis, exactly opposite to the sympathetic system, which is fright, flight, or flight, which gives you open eye, bigger pupil, sweaty brow. Horner syndrome. So then you need to go and check further. But did he not maybe pull it? It's normally traumatic. Fell, grabbed onto something, sportsman, did some vigorous exercises in the area, or he had recent surgery to help with his Raynaud's, or he has, you got to do x-rays, check him out for Pancoast tumors, something pushing on the sympathetic trunk, which hugs the carotid artery. Né? It hugs the carotid artery. So any problems there will give you a Horner syndrome, sometimes even just virus infections of the sympathetic trunk. So Horner syndrome, ptosis, meiosis, anhidrosis. Right, let's move on to another one. A week later, you get called to casualty again. They've got a recent onset ptosis again, unilateral ptosis. And you think, well, okay, Horner's is in the back of my mind. This could be a Horner syndrome. You go and see the patient, and you have a look, and it's a little bit worse, this ptosis. But there's a ptosis. And you think, okay, Horner's, so what's the next thing to check? Check his brow. No, he's got normal sweating. And now you go, but the eye looks sort of semi in an abnormal position. So let's test his eye movements. And you have a look, and he can do almost no eye movements. And he can only look down and abducted in a downward position and an abducted position. Why? Because his fourth nerve is working, which is down, and his abducens is working, his sixth nerve is working. So if your fourth nerve is working and your sixth nerve is working, how is your eye going to be? Your eye is going to be like a day after lectures, down and out. You're going to be down and out, right? Down and out with all the knowledge that you've gained. So remember this, down and out. If the eye is in the down and out position, you've got a third nerve palsy. Eh? A down and out eye is a third nerve palsy, especially associated with the ptosis, because your oculomotor nerve is not working. But your fourth nerve is working and your sixth nerve is working. Now, how do you distinguish between you do this guy's pupil reaction, and you find that his pupil reaction is normal. So in your Horner syndrome, he had a small pupil. In this one, he has abnormal eye position, and his movement of his eye is restricted in conjunction with his third nerve. So now you need to know, is this a dangerous situation or isn't it a dangerous situation? Because a third nerve palsy is potentially one of the absolute emergencies where you can pick it up in the eye and pick it up early. So if let's go down to anatomy a little bit. This will help you very much in the future. If you take a cross section of your nerve, of your third nerve, the pupillary fibers are on the periphery. Your pupillary fibers are on the outside, and all the rest of the fibers are centrally. So if you take your vasa nervorum, your vasa nervorum, your artery that feeds this nerve, what happens is it comes and it dives in and it feeds the nerve from the inside out. It feeds the nerve from the inside out, your vasa nervorum, okay? Your pupillary fibers are then obviously last to be involved. So what you're going to have is you're going to have a progressively more and more eye that looks more and more down and out as the third nerve dies, but the pupil will be relatively spared. So if your pupil is relatively spared in the presence of a third nerve palsy, you've probably got a problem with your vascular supply, with your vasa nervorum. And therefore, it's a medical disease where you have to find out what is wrong with this guy's vasculature. Very often hypertension, diabetes, these medical diseases that need to be tested and need to be treated. And it is not an absolute emergency. You've got a bit of time to get some help and do some more investigations. If, however, the pupil is involved and you have a dilated pupil, if you have a ptosis with a down and out eye and the pupil is involved, it means something is squeezing on this nerve. And what things squeeze on nerves? Aneurysms and tumors. So this could be an early sign of an aneurysm or a tumor that is squeezing on this guy's third nerve. Normally sort of internal carotid, anterior communicating, that sort of area is where the third nerve runs past. So very important, pupil involved, surgical disease. He needs dynamic MRIs. He needs to be neurosurgeons involved. He needs to be investigated very, very quickly and treated with absolute emergency. When the pupil's not involved, you have a little bit more time, and it's probably a medical disease and will come right if the vasculature comes right. Right, so that's very important. Let's quickly go through the sixth nerve palsy. If you've got a sixth nerve palsy, it often happens that you get an isolated sixth nerve palsy with trauma, head trauma. So what happens, especially coup contra coup type trauma. In other words, a guy's playing soccer. He's the goalkeeper, and he gets a ball flat in the face, and he gets this jarring of his head. The problem with this, there's a small design error in the sixth nerve. The sixth nerve comes out and runs a tiny little nerve, runs, and it's got a long course before it gets to the lateral rectus muscle, and it sort of creeps over the petrous bone, Peter strong, the rock, the hardest bone in the skull, which houses the cochlea. It sort of crawls over the edge of it, and that's where it's vulnerable. So a little bit of a coup contra coup, bang on the head can damage that nerve slightly, and he can get a sixth nerve palsy. Normally, those sixth nerve palsies improve because they're not completely severed and they're just damaged, and they can come right in the end. All right, so ptosis, meiosis, anhidrosis, Horner syndrome, down and out eye with a ptosis is a third nerve palsy, pupil involved, probably a surgical disease, very, very important. Pupil not involved, probably a medical disease. Right. Now, there's one disease that we need to talk about at this stage is myasthenia gravis. It's the great pretender, just like you have lots of great pretenders in medicine. TB is a great pretender. When you're not sure what the diagnosis, always have TB in the back of your mind. HIV is a big pretender. So when you're certainly struggling to get a perfect diagnosis, those are the diseases to think about. When eye movements are involved, and you are not too sure, and it doesn't really want to follow the anatomy. It's not really a down and out eye, and some of the third nerve is working and the rest of the third nerve isn't working, and there's maybe an isolated fourth nerve gone, and the sixth nerve, and it just doesn't make any sense. Think about myasthenia gravis. Myasthenia gravis, important disease as far as eye movements go, because it affects the eye movements in a haphazard, non-anatomic, respectful way. The pearl there, though, is that myasthenia gravis never involves the pupil. So if you do your pupil reaction and that's normal, then know that you may have a myasthenia gravis, especially in an abnormal movement of the eye that you can't explain. A little test that you can do there is called the ice test. You put some ice in a bag or in a cloth, and you put it over the ptotic eye, and if the ptotic eye improves, he's probably got myasthenia gravis. So a way to do that, if he hasn't got a severe ptosis, is to fatigue him a little bit. In other words, say to him, look up, look up, look up, look up. And initially the lid is up, as he looks up, and you say, and then the lid falls, and you say, look up, come, 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 come. And you've got to really push him a bit, and the lid falls a little bit. There's a bit of fatigue happening there. When you have him at his, the ptosis at its worst, and you put the ice on there for a minute, and it improves, you've probably got myasthenia gravis. What a lovely, non-invasive, very accurate test. It's basically the cold of the ice is a acetylcholine esterase inhibitor. So in other words, your acetylcholine esterase doesn't eat up the acetylcholine, and there's a buildup of acetylcholine, and the ptosis improves. Myasthenia gravis, important one to have in the back of your mind. Right, that's some interesting diseases that are associated with movement, pupils, ptosis, and hopefully you can now test those muscles. Remember to get them into line. The only way you can do that, oblique muscles, he must adduct. Rectus muscle, superior and inferior, he must abduct. And the lateral medial and lateral rectus is easy. He's already in the primary position. They're already in line. Right. So now we can move on. This is the end of this video, and we will, in the next one, we will speak a little bit about common diseases that you are confronted with, that you should know how to handle, but you sort of don't know exactly how to handle. You don't know how to make sense of them all. Some common diseases that we need to nail down so that we can, with confidence, make good diagnosis and treat well.